Professor John Yarnold, welcome. Thank you for giving us a couple of minutes during this very busy ESTRO meeting. You were presenting some data on hypofractionation yesterday in breast. Would you like to tell us about that and the trial that you presented and a new one, Fast Forward, I think it's called?
Yeah, that's right. I was presenting on behalf of UK breast fractionation trialists who have been testing over the last 10 years fewer, larger daily treatments of radiotherapy for women with early breast cancer, given to a lower total dose than we did before, with the objective of exploiting the better anti-tumour effect of slightly larger treatment sizes, and also shortening the treatment time and making it more convenient for patients and also for health services cheaper. But the primary driver is clinical effectiveness, safety and efficacy. And we've shown with 6,000 patients in our randomized trials over the last 10 years that we can cut the number of daily treatments from 25 fractions in 5 weeks to 15 fractions in 3 weeks. And what I was doing yesterday, my first of my 2 presentations in the afternoon, was to update that slide to median of 7-8 year follow-up, ranging from 5 to 10 years. So those are fairly mature data. I was also presenting early results of a trial which is testing the traditional 5 weeks of radiotherapy treatment, 25 treatments, small fractions, against 5 larger treatments to a much lower total dose given once a week over 5 weeks, and showing that we would be able to identify a schedule of 5 fractions delivered once a week that would be equivalent to the 5-week schedule of daily treatments, at least in terms of the harmful effects on the healthy tissues of the breast, which are in any case mild, but nevertheless we want to know about them. And yes, you're right, our next trial is called Fast Forward, and that would be a phase 3 trial of 4,000 patients due to start in 3 months' time, which will test our standard 3-week schedule of 15 fractions against a 5-fraction schedule delivered in 1 week. And so we're really interested in that. We think there may be clinical advantages arising from the biology of radiation effects on cancers that will make that more effective and at least as safe as what we're doing now. And of course, a 5-day treatment for women with breast cancer is going to be a very different experience from the 5 to 7 weeks that they may be receiving today.
Sure. Now, you mentioned breast toxicity being a minor issue. Are the days of cardiotoxicity gone now with good planning and careful targeting?
Well, for patients treated over the last 5 decades, they're not gone. No. But for patients treated today, I would say that the technology exists to protect the heart, to exclude the heart. And the technology can be very simple. It can be, for example, breathing in and only treating the woman when she's in inspiration, and where the breast moves forward, the heart is pushed back. For women treated with left-sided tumours. And there are various ways of doing this. The woman can either hold her breath in, for example, or the machine can be calibrated only to treat when she is breathing in, so-called respiratory gating. And there are other really simple techniques for shielding the heart in the minority of women, about 30% of women, where there would be the tip of the heart that would still push into the back of the treatment during radiotherapy. Yeah.
So the other issue you've been involved in yesterday, a very busy day yesterday.
Yeah, it was.
You had a one-to-one debate with Roberto Orecchia. Now, I declare a conflict of interest here because I work at the European Institute of Oncology with Roberto, and I know all about the Elliott trial. I know quite a bit about partial radiation, not as much as you though. Roberto said yesterday that there was an amicable agreement that there was no mature data yet in the various trials. Any other slant you'd like to put on it?
That's an understatement, and he would agree, I think, that there are very, very few mature data. For example, if one, after whole breast radiotherapy, if one assumes that the 5-year local relapse rate in the breast is as low as 2.5%, which is terrific for women, but 2.5%, then in order to detect a 3% inferiority, in order to detect
equivalence.
Well, yes, equivalence, but to exclude the fact that the recurrence rate may not be 3.5% or 3% worse than that, you need at least 50 events arising in 1,500 women who have had 5 years of follow-up. Okay? And at the moment, there are 20 events in fewer than 400 women with that duration of follow-up. The only trial with that follow-up is a Hungarian trial. That's a landmark trial by Polgar and colleagues in Budapest that have published 7-year data, but that trial is less than 300 women. So the only other data that's published is from the Target trial, which is an international collaborative trial of intraoperative radiotherapy. They published their data a few weeks ago based on a median follow-up of 2 years. And they made quite strong assumptions based on their very preliminary findings as to what their 5-year data would probably look like. And on that basis, drew quite strong conclusions. And whether that was a helpful thing to publish that early, I think is controversial.
You and I would not accept that, would we, John?
Well, no, I think on behalf of our trialist groups, because I'm clinical investigator of the UK partial breast trial, and we've decided that we would not publish until we had a median survival of 5 years, which is how we've dealt with our fractionation trials.
Now, there is an issue of women having heard about this sort of intraoperative therapy and demanding it, asking for it, beating the drum. And Roberta was saying that there is, in response to this issue of being treated outside a clinical trial, which you and I would both strongly advocate would not happen. The guidelines coming from the American Society and also ESTRO, which patients might be acceptably treated outside a clinical trial? Yes,
those are very, particularly the ESTRO guidelines from North America are I feel there's a strong inconsistency in there. I recognise a difficulty. If you're a centre, particularly in the private sector, that invested largely in a piece of equipment, you participate in a trial, the trial stops and you have to put a dust cover over that piece of equipment for 5 years, I can see there's a problem. But there's a problem for the patient who's going to be treated on that piece of equipment without mature data. The thing is that in that kind of context where you've got other pressures, you've got potentially private pressures, commercial pressures, as well as the scientific and clinical pressures. I can see how in the United States 50,000 women have been treated with Mammosite outside of protocol. With no randomised trial. The randomised trial is still ongoing. Yes, it's extraordinary. So those are real threats to science and that threaten to undermine the quality of evidence and will rebound badly on the professions and, of course, most worryingly, potentially damage our patients. And I think the ESTRO guidelines say, yes, they strongly encourage participation in a clinical trial, but we know a tiny fraction of those patients are going into clinical trials. And they say otherwise, they define suitable groups and possible groups, they call them cautionary groups, who after counselling may be treated with this modality, despite their, yes, unproven long-term efficacy, unproven long-term safety, and actually more costly. Sure. More costly.
Now, at this meeting, there are lots of knives around, radiosurgeons all over the place. There are cyberknife people and tomo people and gamma people and rapid arc people and so on. And I look at it from outside and say, okay, where are the clinical trials in this area? And are we setting these up? Are we actually going to compare, say, the rapid arc versus HIFU in the liver, high intensity focused ultrasound, for instance, which came from your institute originally? There seems to be a bit of a resistance. What's your view on that?
Yeah, there is a complex issues there. There are different ones. One is that it is true that it's difficult to compare technologies which are very different. There are, for example, to take an example from breast radiotherapy, there would be an issue as to whether you can actually integrate the results of, say, trials conducted with intraoperative radiotherapy, the Elliott trial, with those of the Target trial, both delivering highly localized intraoperative radiotherapy, or whether you say, look, their rationale and technical qualities are so different that you have to evaluate those technologies separately. And that sort of, if you like, that analogy would extend right the way through medicine, in fact, and it would not be peculiar to radiotherapy. Indeed. And I think there would be some, if you like, some middle ground where one would define certain parameters that one considers important, but these would be clinical parameters. In radiotherapy, it would typically be, say, a volume. That would be a starting point. And say, look, we don't mind what technology you use to actually conform to that volume, but that would be the requirement. I think with other physical technologies by ultrasound, for example, and radiofrequency, then clearly those would need separate head-to-head comparisons, and I'm sure those are planned.
Okay, let's hope so.
Yeah.
John, thank you very, very much indeed. I'm sorry for keeping you long, but it was the most interesting conversation.
It's a pleasure. Thank you, Gordon.
See you again.